Welcome to Clinical Tools Library, evidence-based scales and questionnaires designed to support healthcare professionals in practice. The modified Ashworth scale assesses muscle spasticity by measuring resistance during passive soft tissue stretching. It quantifies the severity of hypertonia in individuals with neurological conditions such as stroke, cerebral palsy, and multiple sclerosis. The scale categorizes muscle tone on an ordinal scale ranging from 0 to 4, where 0 indicates no increase in muscle tone and 4 indicates rigidity. Its main purpose is to provide a standardized and reliable method for clinicians to evaluate changes in muscle tone over time. This facilitates treatment planning and monitoring of therapeutic interventions targeting spasticity. The modified Ashworth scale is indicated for patients exhibiting increased muscle tone due to upper motor neuron lesions. It is most commonly used in populations with conditions such as stroke, cerebral palsy, multiple sclerosis, and spinal cord injury. The scale provides a standardized method for assessing spasticity in clinical settings, particularly during neurological rehabilitation and physical therapy. It assists clinicians in quantifying muscle tone changes over time and evaluating the effectiveness of interventions aimed at reducing hypertonia. The tool is primarily applied to measure resistance during passive soft tissue stretching of major muscle groups in the limbs. The modified Ashworth scale consists of 6 items evaluating muscle tone through passive movement of selected muscle groups. The examiner moves the joint through its range of motion at a specified velocity while observing resistance to stretch. Each muscle group is assessed individually with a focus on spasticity in upper and lower limbs. The response format is a 6-point ordinal scale ranging from 0 to 4, including a 1+ grade. 0 indicates no increase in muscle tone, 1 represents slight increase with a catch and release, or minimal resistance at the end of the range. 1+ shows slight increase through less than half of the range, 2 indicates more marked increase throughout most of the range, but affected part remains easily moved, 3 reflects considerable increase limiting passive movement, and 4 corresponds to rigid joints in flexion or extension. Scores are recorded for each muscle group and used to quantify spasticity severity. Higher scores suggest greater spasticity severity, while 0 denotes normal muscle tone. Clinical interpretation considers the distribution of scores across limbs to inform treatment strategies and monitor progress over time. The modified Ashworth scale demonstrates variable sensitivity and specificity depending on the study and patient population. Sensitivity refers to the ability of the scale to correctly identify patients who have increased muscle tone or spasticity. Specificity relates to correctly identifying patients without increased tone. Studies report sensitivity ranging from 60% to 85%, indicating the scale detects true cases of spasticity with moderate accuracy. Specificity values are often lower, between 50% and 70%, reflecting a higher rate of false positives, where normal muscle tone may be misclassified as increased tone. In clinical practice, this means the modified Ashworth scale is more reliable in confirming the presence of spasticity than ruling it out. For example, if a patient scores high on the scale, there is a strong likelihood of actual spasticity, but a low or 0 score does not definitively exclude its presence. This limitation underscores the need for complementary assessments alongside the scale. The modified Ashworth scale was developed in 1964 by Ashworth to provide a clinical measure of muscle spasticity by assessing resistance during passive soft tissue stretching. In 1982, Bohannon and Smith introduced modifications to improve its sensitivity and usability, resulting in the modified Ashworth scale commonly used today. Validation studies have examined its reliability and correlation with other measures of spasticity. Research by Pandian and colleagues demonstrated inter-rater reliability coefficients ranging from 0.6 to 0.9, indicating moderate to high consistency among different examiners. Concurrent validity has been supported through moderate correlations with electrophysiological assessments, such as electromyography and biomechanical measures, suggesting the scale reflects underlying neuromuscular hypertonia. However, some studies have identified limitations in differentiating between neural and non-neural contributions to increased muscle tone, highlighting the scale's focus primarily on resistance to passive movement. Despite these limitations, the scale remains widely used in clinical settings due to its ease of administration and ability to provide quantitative data relevant to motor function impairments in conditions such as stroke and cerebral palsy. Thank you for watching. For complete information and official PDF resources, visit clinicaltoolslibrary.com or check the link in the description below. And don't forget to like and subscribe for more clinical insights.